I'm in the clinical microbiology at UK. My case study is going to be on E. coli ESBL. What is ESBL? ESBL stands for extended spectrum beta lactamase. ESBL is an enzyme produced by some Enterobacteriaceae. E. coli and Klebsiella pneumoniae are two common bacteria that produce the enzyme. ESBL destroy antibiotics such as penicillins and cephalosporins and cause them to be ineffective against treating infections. How common is ESBL? Because of the resistance, there are fewer antibiotics available that can treat ESBL infections. Common infections such as UTIs can require hospitalization and IV carbapenem antibiotics. According to the CDC, in 2017, there was 197,400 cases of ESBL in hospitalized patients and 9,100 deaths in the United States alone. An individual may either be colonized or infected with ESBL. In either situation, the germ is present on the skin or a body opening. If you are colonized, it means that you have no signs or symptoms of illness. If you are infected, it means that the disease is present and causing illness. If you are colonized but not infected, a special diet, hygiene plan to wear gloves and avoid minimal contact with others may be recommended to prevent the infection from happening. The signs and symptoms are different depending on the site of infection. If you have infection of the gut, you may also have loss of appetite, bloody stool, stomach cramps, diarrhea, excess gas or bloating, and a fever. If you have infection in the blood, you may have fever, disorientation, chills, nausea, vomiting, or trouble breathing. Who is at risk? Most people that have exposure in the healthcare industry. Some can be healthy people that may have a urinary tract infection, while others may have traveled outside of the United States where these germs are common. This list of people are the most susceptible to ESBL. Older individuals, those with weakened immune systems, those with cancer or diabetes, those treated with antibiotics previously, those who have had recent surgery, those who have repeated or long hospital stays, those who have open wounds or sores, those who have tubes, drains, or catheters, anyone with contact with patients and or clients that has ESBL is at higher risk. How is ESBL most often spread? It can be spread from one person to another through contaminated hands mostly. How to avoid getting ESBL? Washing of the hands after using the bathroom because ESBL producing germs live in your GI tract. Wash your hands before eating or preparing food. Healthcare providers should wash hands or use hand sanitizer before touching a patient or handling medical devices. If you travel abroad, take into consideration food and water safety. Thorough cleaning of medical equipment and services in the patient's room. In the hospital, isolate the patient. At home, family members should wash hands before visiting and leaving if personal care is given. Washing laundry in warm water with detergent. Using disinfectants such as Clorox or Lysol to wipe down contaminated surfaces. For hospital isolation, if the patient is in the hospital, they should be put in isolation, and this means being put in a private room, contact precaution sign placed outside of the room, healthcare providers wearing proper PPE, healthcare providers following proper hand hygiene upon entering and leaving the room, limiting exposure outside of room, only for diagnostic procedures. ESBL is treated with antibiotics that they are not resistant to. Patients may have to be hospitalized and receive IV antibiotics. If ESBL is a cause of serious infection, then carbapenem is used. It is reserved for highly reserved infections. Anyone can get the infection, and almost any infection can lead to sepsis. And this is what my case study is about. It's a 91-year-old male presenting to the ER with sepsis. This is the urinalysis result that we got. They sent 2 specimens. The first specimen was a cath urine, and the second specimen was also a cath specimen. The first slide that we look at, the first line is of the second specimen that we received. And as you can see, the second specimen was yellow and turbid. It also had 3+ protein, 3+ occult blood, 3+ leukocyte esterase. The microscopic was WBCs were too numerous to count. RBCs was 15 to 20. And a manual dipstick had to be performed on this specimen because it was so turbid that the machine was unable to read this result. The first specimen that we got was when the patient first came into the ER and they cathed him. As you can see, there's a big difference. It was just hazy to begin with. It had only 2+ blood, and the white blood cells was 20 to 30. The red blood cells was 0 to 5, and he had 2+ bacteria in both. What happened was, after they sent the first specimen, I'm assuming that all the pus that he had in his bladder came down once the catheter was inserted, because they said it was just a big pus ball when it came out the tubing about an hour later. These are the urine culture results. As you can see, he had greater than 100,000 E. coli ESBL positive, and that the resistant organism requires isolation protocol. He also had blood cultures drawn while he was in the ER, and this set, both bottles were positive, and the gram stain was gram-negative rods, and it also came back as E. coli ESBL positive. And then the second set of blood cultures, he only had 1 bottle out of 2 that was positive, and it gram stained gram-negative rods, and it was also E. coli ESBL positive. And all 3 of the susceptibilities had the same exact resistance and susceptibilities. And as you can see, all the cefetin drugs were extended spectrum beta-lactamase positive. And the penicillins, the ampicillin, and the I think that's all he had was the ampicillin. It was also resistant. This is just the case study. The patient presented to the ER with sepsis. The physician ordered the normal labs, CBC, CMP, blood cultures ×2, lactic acid, and a urinalysis culture, reflex to culture. As I said in the previous slide, the first urine that came up didn't look that bad, but when they sent the second one up, it was horrible looking. It was just so super thick, and it just looked like pus. Just looked like a big bunch of white blood cells. The cultures, they came back as ESBL, E. coli as well. I think the patient was admitted to the hospital and he received antibiotics, and he was sent back to the nursing home. And he has not been back since, so I'm assuming that he was resolved. And these are just my references. Thank you so much.